targeted drug delivery, intrathecal pain pumps. A show of hands, how many people do these? Okay, just a few. I'm going to make a case for you why you should start doing them or do more. So we're going to talk a little bit about the hierarchy, treatment hierarchy, where this fits in. We'll talk about incorporating this into your practice, the whys and the hows. And I'm going to talk to you about something we don't often address, is the economics of this, and we're going to address this head on. Anybody know what this is? This is the inverse pyramid of stomatos. And this is when it came out, 2005, this is kind of where we were. Some interventional techniques, ablative therapies, and really not much in terms of everything else. The corrective surgery at that time was primarily done by surgeons, and it wasn't done in a minimally invasive way. And typically the way that we apply it is in our practice, we apply body part. We don't do systemic therapy whenever a person has a problem with the L4-5 disc or has a fracture at T12. We fix that. We don't just cover over it. We don't put a pain blocking device in. We're actually able to do some interventional therapies and techniques to take care of this, and this is kind of how we approach it. And we click down, stopping with the least invasive thing that actually provides durable relief for that patient. And that's the fundamental philosophy that allows us to target a specific area. And so what it looks like today in 2023 is we have a lot more corrective surgical procedures that are minimally invasive. And this is something that you just saw in the room next to us, and you'll see more this afternoon. And then the opioids are all the way down at the bottom, just above salvage procedures, very appropriately, because chronic opioids ruins people's lives. And the dorsal column stimulation and targeted drug delivery is right at the apex, the pragmatic apex of what we do. And targeted drug delivery is unique. It's intrathecal. It's much more of a low dose. Typically, people think of targeted drug delivery associated with cancer, tumors. So let's just take that just for a second. Let's take the tumor part of it. And so when this was evaluated, there were about 1.5 million people with cancer a year. That's up to almost 2 million now. This data is about a decade old. And so out of that, about 2/3 of them will have pain, half will have severe pain, and about 30% of those will have severe pain that's not treated with conventional therapy. And so this is pretty easy. And when you combine that with problems, and we'll come back to this, there's over 100,000 people a year dying of opioid deaths. And this is another method for treatment. Whenever we discuss targeted drug delivery, we talk about the dose, and we talk about the difference between systemic narcotics. I made the comment that really we shouldn't be prescribing opioids for chronic pain conditions. There are a few exceptions, maybe long-term cancer is one of them. But if you prescribe an opioid systemically, whether it be a patch or a pill, you'll eventually develop narcotic-induced hyperalgesia, greater the dose for less and less effect. And you talk to people that's been on chronic narcotics for a long period of time, and they'll tell you it doesn't really work that well because it stopped having an impact. But whether it's IV through a patch, IM, or oral medications, all of these are systemic. The dose for the targeted drug delivery in the intrathecal space, focusing on the dorsal horns and the spinal cord, hits at the normal receptors, and so the dose differential is about, in an opioid-naive person, is about 1 to 300. So 300 milligram equivalents by mouth is equal to 1 milligram intrathecally. And a non-opioid naive, it's about 100 to 1. So if somebody's taking 100 milligram equivalents by mouth, it's equal to about 1 milligram. And how does it do? Well, if you look at this is data from Tom Smith, Peter Stotts, the late great Lisa Stearns, and we have better pain reduction. So it's better than the optimal management for patients with cancer. It also has reduced toxicity, which would kind of go along with, a more controlled and smaller dose. And it has a better survival, so people actually live longer whenever you have an intrathecal pump. In terms of utilization, this is what we use. We kind of make sure the patient has more than 6 months to go, primarily because of the cost benefit of all this. And This is a former paper from Dr. Stearns that compared everything from the emergency department, inpatient, outpatient, all the way to hospice, and said the utilization was significantly less in all points of service for patients with targeted drug delivery than medical opioids. And the high-dose opioids, turns out, very expensive. And the crossover, even though a pain pump is fairly expensive in and of itself, as long as it lasts every 7 years, you have the recurring expense, but generally it stays flat because the medication is not expensive. So one of the things, my background is I'm an interventional radiologist, and I don't really understand why more IR people of that practice persuasion don't place intrathecal pain pumps, because they'll diagnose it, they'll biopsy it, they'll put ports, Mediports in, they'll put infusions, they'll do ablations, TACE, Y90, and other embolics. But when it comes to the very most effective thing of all, they typically don't place intrathecal pain pumps. And I'll give you a few reasons why that is, and I also will hopefully dispel that for you. So the pump implantation is very straightforward, typically in the right or left lower quadrant, an incision just big enough to get the pump in. Pump is placed, tunnel the catheter over, place it intrathecally, connect the catheter to the pump, and then it's refilled using a needle guide and refilled through the skin. So for those of you who don't place pumps, these are 6 areas that you're taking a swing and a miss on. So severe spasticity, things that you can't manage with oral anti-spasm medications like oral baclofen. So uncontrolled cancer pain, that's pretty obvious. When pancreatic tumor, this tends to be very painful. Also bone metastases tend to be very painful. So multi-site pain. Patients, for example, with severe degenerative change, degen scoli, 80-year-old female, not a surgical candidate, has thoracic pain, neck pain, low back pain. And how are you going to manage that without an intrathecal pain pump? Arachnoiditis. Does anybody ever recognize this? I would say I have not seen a case in 15 years that was diagnosed prior to our seeing it. Don't you think, gentlemen? It's not that unusual. And arachnoiditis is very effectively treated with just a little bit of intrathecal medication. And then patients that are on high-dose opioids are not able to reduce. Get somebody on chronic grinding high-dose oral opioids for 20 years, very difficult for them to come down and off of it, especially if they start when they're younger. So these are, if you don't do pumps, you're not effectively treating these people. These are effectively only treated with targeted drug delivery. So how well do people like their pumps? Anybody know this registry? It's the PSR registry from Medtronic. So out of everybody that has a neuromodulation system, a dorsal column stimulator, spinal cord stimulator, how many of these, once they come to the end of the life of the stimulator, get replaced? What do you think? What's the number? Give me an approximate percentage. 40, it's even lower than what I thought you'd say. About two-thirds, about 60%. What percent of people, when the pump is at the end of life, want it replaced or have it replaced? 99.5. There were 4 people in the registry out of 831. Out of those 4 people, 1 wasn't placed because of an abdominal wall infection. 1 had resolution of pain, so it's really only 2 people out of 831. That's 99.7% of people want their pump replaced. So if these are so good, why aren't they more commonly utilized? So the most common misuse of this is orals on top of pump. That is a no-go, never do that. Let me give you an example. So I said 1 to 100, and I typically will use that. And before 2017, when we had state laws preventing high doses of oral opioids, people would come in on 200, 300, 500, 600. We had one guy come in on 1,200 milligram equivalents daily. It's craziness, right? And so he's opioid tolerant and 1 to 100. So based on my calculations, I should have given him 12 milligrams of intrathecal morphine as a trial dose, bolus. So I didn't do that. Why? Because it just seems wrong, right? 12, enough to kill an African game elephant. I gave him 8, right? Gave him 8 milligrams. You know what happened? Stop breathing. No, he didn't stop breathing. He did great for about 3 hours. No pain at all. And then after 3 hours, it started to wane, and he started yelling and checked out AMA. Very predictable, right? The point is there's no amount that you can pour into the intrathecal space. If you have your cytochrome P450 and your liver revved up, you've got smooth endoplasmic reticulum from here to the sun and back, and you are just chewing through that stuff. You take a handful of Percocet, where does it go? It goes into the stomach, the small bowel, into the jejunum. And what is the jejunum blood supply? Where does that go? It's drained by the inferior and superior mesenteric vasculature into the portal vein, dumps right into the liver. 80% of the blood supply to the liver is through the portal vein, not the artery. And so you're just chewing this stuff up. You can't dump enough intrathecally to help that person, but I see it all the time. Orals and pump don't mix. You're short-sheeting the person. You're sabotaging your own therapy. It just never should be used together. So tradition, you're married to somebody with a pump. I've heard this numerous times, and this is misinformation apparently passed on by anesthesiologists. What does that mean, actually? Clint, what does that mean? I mean, so one of your patients come to you and they have a pump, you'd probably see them, right? What if they didn't? What if they had a spine fracture? Just came to you because they had a recurrent back pain. Would you, I can't see you. No, you see your patient's back, just like any other patient. Pump patients are just like any other patient. So the problem with the pump, it's created a generation of people that have taught the next generation not to do it. You know, it's very similar to, Neil, it's very similar to vertebral augmentation in Australia. Some of our southern hemisphere brethren have no idea that it's like a desert, like an interventional spine desert. People there don't do augmentation, and they didn't because of the Rochelle Buckminder's fiasco of an article in 2009, something I addressed with you yesterday. And now people don't do it, so they won't do it, and the cycle continues, and pretty soon there's nobody doing it. So anybody know the difference between complicated and complex? So pumps are complex. Complex is an Italian sports car and a jet engine. That's complex. Complicated, my wife is complicated. So pumps are not complicated, they're just complex. And so this is something that takes a little time to learn. And then when we place and we manage, separating people who place pumps versus those who manage it creates a treatment gap. So the best people to do it are the people that place them and manage them, can take care of all the issues and complications. And, the final one I see, it's not worth my time. It's not worth my time. Dr. Schonard, what's your time worth? It's very expensive, isn't it? You know, good program in Texas. I mean, you got big shoes to fill. So let's see what our time is worth. Well, it's very broadly reimbursed, isn't it? Everything you do with the pump is reimbursed. Everything, broad reimbursement. And in the first year, you have about $5,000 of profit off of a pump, including placement. Years 2 to year 7, it's about $2,587, electronic analysis, reprogram, catheter and rotor studies. Every time you see a patient, every time you refill it, you get reimbursed $2,587. Any MBAs in here? No? So this is called the present value of future cash flow, and they teach this in business school. And that looks like a scientific calculation, right? And that's present value of future cash flow. So what is a pump patient going to generate for your business in terms of gross collections, right, for year 2 and beyond? You remember what I said? $2,587, right? So over the course of time, it has a total value of about $15,000. And this is a typical calculation. Present value of future cash flow. So if you have a couple hundred pumps, what is that going to generate over the life of that pump? About $3 million. So, Dr. Schonard, is it worth our time? Both Dr. Schonards and Nell is also nodding her head. It is worth our time. And so that is a total and final misconception about pumps. So, bottom line, there is a treatment hierarchy, and as you've seen in that room next to you, the treatment hierarchy has dramatically changed over the years. This is a 10th annual fellows course. I think I saw one table that we were teaching 10 years ago, and 9 new tables. So, and we're only at the toe of the curve. We're at the start of the logarithmic uptick, and new stuff is coming down the pike all the time. If you don't think there's anything new, everything that is new is either here. I'll give you 4 or 5 clinical trials that we're about ready to start in the next year, things that people haven't even heard of. So it's starting to come fast and furious. Targeted drug delivery can only do a few certain things, and if you're not doing it, you can't take care of those patients adequately. I would dare you to try to establish the level of complexity in your practice necessary. This is rote, and once it's a learned skill, and once you learn it, once you understand the patterns, once you understand the method of treating patients with targeted drug delivery, it's very easy. And there's even a book to do it. I wrote one last year. So this is something that you can have as a reference. It's very practical. It tells you exactly what to do in different scenarios. And I think it's worth incorporating into your practice, especially for the 6 reasons I mentioned. It's a natural extension of what you guys do for cancer and for pain. It is very effective. It's completely sustainable. And as I've shown you with the future value of present cash flow, it is very profitable. And I consider this, because of those attributes, to me, this is absolutely essential. It's one of the best things we do in our practice, and is absolutely an essential part of it. Thank you very much. Let's open up questions, comments.
Thank you, Dr. Beall. I'm just curious, a couple of things. Is there a way to expedite the process of evaluating the patient appropriately for a pump? Do they have to be refractory to prior controlled substance use? Is the current recommendation, I'm in the process of writing up a cancer pain summary for Elsevier and sort of trying to review some of the literature about monotherapy versus compounded. Just curious how things are shaping up. And is there also a general overgeneralization about, opioids bad, we're in a crisis, we can't continue to manage patients using this modality?
So it's pretty open. You're not really required to have failed previous therapy. You're not even required to have failed opioids, for sure. And so you just have to be the right fit. And typically, the right fit is somebody that is not repairable using our minimally invasive or maximally invasive techniques. If somebody is on chronic oral opioids, it's about the only way to really treat them. They become so hyperalgesic, there's almost nothing you can do. And the trial is very open. There's no psychiatric requirement for this, as there is for neuromodulation, which is strange but true. And it's the threshold to approve and do trials and place pumps is exceedingly low. You can do it for almost any reason. I would encourage you to do it for a valid reason. Cancer or severe pain, multi-site pain, these ones I listed, these are my favorite things to do, is to place somebody in one of these cases, especially somebody with arachnoiditis, for example. I see stimulators go in for arachnoiditis, which is inflammation of the cauda equina and leptomeninges. Stimulators don't work that well for arachnoiditis. Nothing really works that well, and except for intrathecal drug delivery. Just a milligram or 2 of intrathecal morphine, people do fantastic with it. Very, very safe therapy, far safer than oral medications. Questions, comments? Okay, we will Transition back over into the